Good morning, ladies and gentlemen. Welcome to SIMCON 2025, the 9th annual academic sessions of Sri Lanka College of Internal Medicine. We begin today's program with our first session titled How to Pass MD Long and Short Cases. This session is designed to offer practical guidance and first-hand insights for postgraduate trainees preparing for MD examination. Since the inception of annual academic sessions, SLCIM has remained steadfast in fostering professional excellence and continuous learning. To commence the session, it is my pleasure to invite the moderator, Dr. Rakita Higgoda, to the stage.
Good morning to all. To kickstart SIMCON 2025, we have the How to Pass MD segment, which has been popular among the PG trainees throughout. So the first segment will be on long cases and short cases. The first segment on how to pass MD long cases will be done by Professor Champika Bodhinayaka, Professor in Medicine, Department in Medicine, Faculty of Medicine, University of Ruhuna. May I kindly invite Madam Bodhinayaka to start with her talk.
A very good morning to all of you. I wish you a very pleasant day to kickstart. This is one of the most important topics that we need to cover during this session. And I will just give an outline how what we are going to listen to. So this is our session, Understanding the Long Case Examination. And I'll do a case scenario which appeared for the last exam. And then how you would bring up your case to framework and present and discuss the management plan and what mistakes that you do at the exam. So that is our roadmap. Myth is that it is difficult to fail a long case, but the truth is it is very possible to fail if your clinical approach is flawed or incomplete. So though people say that it is difficult to fail a long case, often it happens if your approach is flawed and the examiners know it. So let's see what is expected in a long case. You already know this. Using the relevant clinical details to build a diagnostic narrative. That means it's not a storytelling. You are using the clues to build up the diagnostic narrative, diagnostic story, not just a story like the medical students do. And integration of the correct multi-system clues which are appropriate. I know the postgraduates love to link everything, but it has to be the correct links. Some things are just red herrings. They are not links. Then most important thing is that you have really very clear and logical reasoning steps to arrive at a diagnosis and a differential, and you have clarity and confidence and a very structured, reasonable management plan. So that is expected in a long case. Let's look at how you are assessed in this case. So this is one of the scripts. I hope it is visible. You can see that the two extremes are 0 to 30 or above 70. So 30 marks each on separate sides. And then you have 10 mark quartiles, right, which is a clear fail, bare fail, clear pass, and a bare pass and a clear pass. So this is your marking scheme. And this is the exam structure and what you are going to be assessed. Some of you might be already knowing it. So the first two components are generally, though there are two separated, they are assessed together. So gathering information in the history and you know all those things to for a diagnosis, and then physical examination and then plan for investigation, and also the examiner is checking your knowledge while this is happening. So these are not one after the other, but everything is happening together, but you make a note, right, of what the student is doing. So clinical long case, most important thing is that we make a diagnosis. 80% of the diagnosis is by our history. 80% of the diagnosis is by the history. Examination either support or refute the diagnosis, right? You might be having encyclopedic knowledge. We see that so many PGs, they read the small print very much, but they have really encyclopedic knowledge, but the reasoning skills are not there. These are gained over your training. And for the diagnosis, if you are unsure about the diagnosis, you have to show logical reasoning, and this is the likely diagnosis. To illustrate these components, I will start with a case vignette which appeared for the last exam, and some of the candidates passed, some of the candidates were clearly failed. So this is, let me read it out to you if you can't see it properly. A 28-year-old female studying overseas presented with worsening leg edema for 2 months. She had painful fingers 6 months ago, which was non-disabling, and actually the student has got some investigations done, and the rheumatoid factor was negative. So there it just passed, not very disabling. So therefore she took some analgesia and it settled. 4 months ago, she had a severe headache and was hospitalized and was found to be having severe hypertension. And at the same time, she had a proteinuria and a hematuria, and at that time the ANA was positive, and quite rightly a biopsy was performed. The patient was treated with prednisolone and cyclophosphamide like for a lupus nephritis. So the patient had proteinuria and hypertension throughout and was developing progressive edema, and the creatinine was persistently elevated. So this is the patient's history. And then on examination, she was cushingoid, obviously because of steroids, and there was pitting edema. She didn't have any facial features of any autoimmune or connective tissue disorder. Both hands were spindled, but there were no deformities. There were no rashes or ulcers. The blood pressure remained high, and the rest of the examination was normal. So this was your case. Let's see the problems and the differentials what examiner is expecting. So we have a patient with edema and hypertension. Most likely it's a severe renal disorder, and ANA was positive, and there had been some arthritis. So obviously you would diagnose here lupus nephritis, and that has to be said that it is class 4 or above, or a mixed 4 and 5. That has to be said. So there's no diagnostic dilemma, right? This has happened over 6 months period. So it is unlike to be a primary glomerulopathy, but it is a secondary glomerulopathy, most likely to be due to a lupus, and that is what is expected. And the patient is progressing into renal failure. The patient is progressing to renal failure due to treatment failure or inadequate treatment for lupus nephritis. And she had been dialyzed couple of times, so the patient says, and she needs continuous dialysis or a renal replacement therapy because this disease is so severe. So how you would handle the case would be, so elicit this history clearly that this is a lupus with a renal disease, not another, because she is not getting better, this could be something else, and bring a lot of unnecessary stuff to the case, right? So this is clearly a lupus, right? So there may be some other, cutaneous features, oral features, hair loss, those things are there, but they are not the most important thing here. Most important thing here is the patient is going into renal failure, and is trying to go and end up with chronic kidney disease. So the examiner want whether you are prioritizing, whether your thoughts are clear, and whether you really grab the problem. So she has relayed the severe hypertension. This is due to renal disease. This is not a young hypertensive. Some people try to link it like that. This is a young hypertension and she needs investigations as far as young hypertension. So it's not the case, right? So this is a severe hypertension and it is probably due to severe renal disease, right? And the disease may be still active or may be advancing to a sclerosis, right? Advancing to sclerosis and going for a CKD. And if you have probed the patient was actually awaiting for a AV fistula creation. So for a renal replacement therapy. So actually this is a 28-year-old girl who has lupus nephritis and going into renal failure, needing a renal replacement therapy, and that is what the examiner want to discuss. Not a lot of stories about whether it is lupus or whether this is a overlap or whatever, which PGs would love to bring into some other unnecessary things. That is not what you really want. You really want that, whether you have got it, and for that you might need a re-biopsy to decide. So that is your investigation and management plan, or you have to intensify the treatment plan, right? But you are presenting something else. So entirely it is how it was done. Some people did it properly and some people did it very wrongly, and some candidates did not make it. So your presenting case, MD is an extended summary, right? It is an extended summary which is specific to the case, and examination findings should include the negatives, relevant negatives, not a list of negatives, right? Few negatives, and you link and interpret the important clues to arrive at a diagnosis and assess the severity, and patient's ideas and concerns need to be taken up. It's really a very distressing situation. 27-year-old going into lupus nephritis, which is a treatable condition. So the candidate has to find that and discuss it, right? And the presentation has to be a flawless continuum. I have listened to some of the candidates presenting flawless story. I don't know how they do it. So beautiful to listen to, and coming up with a management plan. There's nothing to question. Everything that is needed to be said is said. The examiner has only to listen. So bring up your levels to that. So for that case, assessment of the current status and renal function, and so we went through. So those are the things that the examiners are expecting you to do. So this is a management problem. Most of the time, the patient will tell you the diagnosis. I have SLE, I have this, I have that. And you are also very creative in finding the diagnosis. So I know that. So it's not a problem, but the way that you handle the case is the problem. So just because you got the diagnosis, you are not going to pass, because passing is evaluated in that way. So let's see, when there's a diagnosis is a challenge, so how it could be done. Don't give many differentials, give 2 to 3 differentials, maximum 5, right? Don't more than that. I know some of the candidates who have given fever and rash, somebody has given 20 differentials, right? So don't do that, right? So give the most likely thing. If you can't make a diagnosis, not always you can give the reasons, and that show your logical reasoning. This could be one of these, right? But I need some more information to come to a diagnosis. So let's do these investigations like that, right? So then let's go through a case vignette with a diagnostic challenge. Again, appeared at the exam. So I hope the first case is clear, and this is again very common cases. I have taken very common cases. A 40-year-old female, progressively breathless and dry cough for 6 months, and was on steroid inhalers. She had no chest pain, palpitations or PND. She had no hemoptysis or weight loss. She had arthritis of hand joints 2 years, and she was seen by a rheumatologist and was on methotrexate and the symptoms were better. She was not bothered, but the main problem is the breathlessness. She had a rash, erythematous non-pruritic rash 2 weeks ago, which has spontaneously disappeared. And there was a past history that she has had tuberculosis, which was completed treatment, and also a history of recurrent UTI and several episodes of red eyes. Right? So this is the case. So your focus history, so this could be anything, right? So you have shortness of breath, and then there's arthritis, then the rash, and then past history of TB, and there had been some red eyes, so looks like a connective tissue disorder. So then you can't say this is a connective tissue disorder or whatever. You have to tell exactly what connective tissue disorder. So for that, you need to probe into certain things like whether the breathlessness is due to asthma or not asthma. She's on inhalers, but that doesn't mean that it is asthma. Whether it is some other kind of a lung disease, or whether it is a heart, or whether it is the pulmonary hypertension, that you need to figure it out. Or whether it's a diffuse ILD. So that part will come on from examination findings. So, and the patient, next problem is that she has arthritis. So you have to figure it out whether it's a deforming or a non-deforming, and what is the pattern of involvement. Some arthritis have red eyes due to uveitis. So it's a different thing, right? Seronegative arthritis. But this looks like a seropositive arthritis, bilateral, symmetrical, hand joints, like that. You need to figure it out what type of inflammatory arthritis are we dealing with. And the red eyes could be uveitis, episcleritis, scleritis, or conjunctivitis, so that need to be probed into a bit. And the rash, we don't know whether it's what kind of a rash, whether it's a maculopapular rash, or whether it's a nodule, or some infiltrating lesion, or a vasculitic rash. So actually that is how you take the history, so that you know this is the type of thing and this could be the diagnosis. So actually examiner is checking while you are presenting your history whether the candidate is understanding what is going on with the patient, right? So when you present the history. So the differentials could be, if it is asthma, it could rash, red eyes, it could be eosinophilic granulomatosis with polyangiitis, which is like a churg straws. But it could be still, arthritis could be due to rheumatoid, eyes could be due to episcleritis, but the breathlessness could be due to rheumatoid lung, or else arthritis plus ILD or pulmonary hypertension, it could be systemic sclerosis. See, the differential diagnosis could be many. So it could be something like a rheumatoid and a loop systemic sclerosis overlap, or it could be something like arthritis or infiltrations in the lung, sarcoid, and red eyes. Rash could be erythema nodosum, or maybe some other nodule or infiltrating rash. Actually, the patient has had a skin biopsy, and it was not asthma, and it was an infiltrating lung lesion with red eyes due to uveitis. So the examination will tell you whether it is a diffuse lung disease, whether it's a crackles, or whether it's asthma or pulmonary hypertension, so that you can narrow your diagnosis to come to a diagnosis of a sarcoidosis. It's not a connective tissue disorder. So you have probed enough to come to a diagnosis with that history. So certain questions, certain investigations will help you to come to that. So let's see what the examiners are doing during the exam. The candidate is doing this. This is how you're presenting, but the examiners are actually ready to listen to a presentation. They will note your positives, whether you got these things or whether you have what you have missed also, they'll write it down. And during the first 20 minutes, one examiner will question you. While they are questioning, they will revisit. Now they will listen to you, and at the end they will question you back again. What do you think is the red eyes are due to? What do you think is the shortness of breath is due to? What do you think? Like that, they will re-clarify the history and examination findings back again in that 20 minutes that you have. They are not going to go to management part. Then the examiner, so once that is done and once the problem list, do you want to prioritize this list? They will ask, so which you think is best. Or they will ask which problem in this patient needs attention, like in the first case, which problem in this patient needs attention first. Like that they will revisit your history and examination. So that is what is happening in the first 20 minutes. After that, if you have missed some information, they will again question on whether you have taken that part of the history. Then in the examination, they will cross-check your exam findings. They will cross-check everything and your physical examination findings for accuracy. Then the examiners will, after the questions on the diagnosis and differentials, the role will change. Then the next examiner will come in. Next examiner will come in and he will question about your management plan. Generally, so the second examiner is the one who is going to go to the exam management and investigations and the management and the depth of further things like. So by that time they are unlikely to revisit your history unless you have made a real big mess out of it. So it's unlikely. So that is focused mostly on investigations and management, what you would do and what diagnostic investigations are needed or what immediate actions are needed. So that has to be, generally these things are done with lot of practical experience that you have. So generally the MD attracts, generally they are all worked up cases. Rarely you will bring up something like a PUO where it's undiagnosed, but most of the things are fully worked up, gone into kind of treatment midway or at the end. So they are actually, so the management is very important in this kind of cases. So the discussion might start with a current problem which needs to be attended or a complication of the illness. The worked up cases are like that. Then like in the last exam, there was a patient who came with a myelopathy with a complete paraplegia, and the patient had a retroviral infection. So like that, there could be, the patient has come with a complication. So that could be the discussion point, but the original problem is revisited. So examiners will evaluate an approach on management and follow-up plan, as I said, and these are the common errors made by the candidates, which is very important. Some people have very incomplete and unstructured history. I would say it is rare. Most of you do well in your history part. Some people do it like a checklist, like the medical students do. It is not really relevant, right? So like a checklist. So don't do checklist type of histories. This is your bread and butter. You have learned so long, and at the end of your training, you could do a better job. So sometimes they fail to clarify some important points. And the diagnosis is arrived by asking about the diagnosis. Mokak kelada kiwwe, and you know, monet pariksha neda kare, like that, you know, you are asking the patient about the diagnosis and you are really not, then of course you will have a lot of flaws in your history and physical exam, data gathering part. And actually there's no, if you get the diagnosis like that, it's okay to ask what was the diagnosis, but you must do the diagnostic reasoning to come to that diagnosis. So actually, if there is no real understanding about the case, examiner will make a note of it that this person doesn't really have an understanding about this case. And sometimes there's overconfidence on a single clue, like, you know, some people really, if there's a fever and a pharma, it's always leptospirosis, right? Don't put too much of confidence on a single clue, right? It often happens. Fever and a pharma is equal to leptospirosis, which is not, right? So, and also you link the wrong clues, right? So like that tuberculosis here is treated and healed and there was no evidence of TB and there was a recurrent UTI which is not really needed. So like that, wrong clues, don't try to fix it up. Then the reasoning could be inconsistent, and sometimes they adjust the examination findings to fit the diagnosis, which should not be the case. It should not be the case. And sometimes, and most of the times, you give very broad differentials like vasculitis, connective tissue disorder without mentioning what it is. So you have to be very specific. These are the things present and it is this one. It could be this one, but it's most likely this one. So like that, don't give very broad. It could be infection, it could be a vasculitis, it could be a connective tissue disorder, it could be very broad, right? It doesn't give a diagnosis, so it is not at your level. So it has to be very specific. Don't give very broad differentials. So what do the examiners really look for? They look for the clarity and confidence, not of speech, but clarity and confidence of how you handle the case, right? They are pretty obvious. And expected level of skills in data gathering, whether the expected skill here is a senior registrar level or consultant level. That is, if you are doing like a consultant, you are above 70 marks. If you are doing like a senior registrar, you are clear pass. If you are doing like a registrar, you are a bare fail. And if you are doing like a medical student, it's a clear fail or, bad fail. So that is how people, because examiners do it like that. So if you are performing like a senior registrar, you will pass, right? If you are consultant level, that is very clearly very good pass. So like that, that is the level of expectation. So as I said many times, logical flow of reasoning and integration of the correct systems and relevance and consciousness and safe patient-centered management and ability to defend your reasoning politely when challenged, right? You have to defend your reasoning sometimes very politely when challenged. So I hope you gathered. I thought there would be a questions and answer session, but I was told that it is not there. So I hope that you have gathered something to do a better job in the future, and I wish you good luck. Thank you.
Thank you very much, madam, for that elaborative guidance on how to tackle the long case in MD medicine well. I'm sure the PG trainees must have gathered a lot. Next, I would like to invite Dr. Wathulan Sujanita, Senior Lecturer in Medicine, Faculty of Medicine, University of Jaffna, to start the discussion on the next topic, how to pass MD short cases.
Very good morning to all. Thank you, Chairperson, for that introduction. And let me thank the Sri Lanka College of Internal Medicine for giving me this opportunity to speak to the trainees on how to pass MD short cases. So my talk outline would be on examination format, the short case stations, general rules, the domains tested in short cases, individual stations and briefing on that, the common mistakes and how you can prepare for short cases and the summary on that. So as you all know, the examination format, it starts with, MD exam starts with the written component, which comprises 30% of your whole examination, and you should have minimum 50% to pass the written component and at least 40% in each subcomponents of the written examination. So this is a barrier examination. And once you pass the written component, you have clinical examination of MD exam, and where you have the long cases, which was discussed already, which comprises 25% marks for out of all the examination, and you should have minimum 50% for pass in the long cases. Short cases again comprises 25% out of all the examination, And again, you should have minimum 50%, a cumulative 50% for pass. And then you have Viva, which again comprises 10%, and you should have minimum 40% for pass. Similarly, you have observed history taking and communication skills, which comprises 10%, and you should have minimum 40% for pass. So this is what the examination format of MD medicine examination. So in summary, you have written component 30%, and all the clinical examination comprises 70%, and the majority is by the long cases and the short cases, each equally giving 25% each. So moving on to the short cases. So as you all well know, there are 5 stations, 4 major stations: cardiovascular system, respiratory system, abdomen and nervous system, and 1 other system. Okay. So there are certain general rules that we follow in the short case assessments. All of you should be aware about those general rules. So in the 5 stations, each station will have 2 examiners. So you will face 10 examiners in the short cases. Okay. So candidates will rotate in carousel, and in the major system, that means cardiovascular system, respiratory, abdomen and nervous system, the examination time is 10 minutes. That means including 6 minutes for examination and 4 minutes for your presentation and discussion. Okay. In the other system, you have 2 cases to be examined in 10 minutes. That is equally divided into 5 minutes, where you have 3 minutes for examination and 2 minutes for discussion. So you will be examined in 2 cases. A written instruction will be given to each case. So beside the patient's bed, a written instruction will be given. So when you enter into one station, you will see a written instruction pasted next to the bed. For example, say this patient presented with shortness of breath. Examine his respiratory system to find out the cause. So that a very general kind of written instruction will be given. Or examine the eyes neurologically, or examine the lower limbs neurologically. So those are the instructions given to the station. So you don't need to ask anything. Once the bell rings, you can start your examination. So the examination will begin with the bell, and at 5 minutes, one examiner will inform the candidate that a minute is left, just to alert you. And at 6 minutes, a single bell will ring, and the candidate should stop examination and should start to present. And at 10 minutes, a double bell will ring, and the candidate should move to the next station. Say, suppose that the candidate is very competent and finishes the examination early, the candidate will still have time to do more examination, or will have time to recheck the findings. Discussion can commence early once the candidate confirms that he or she has completed the examination. This may be uniform for that particular examination. The examiners all will come into a consensus. For that particular examination, they all may say they will wait until the 6 minutes is over, or they may start once the candidates say that they have completed the examination. So it may change for exam to exam. But remember, once you state that you have completed the examination and start to present, you cannot go back and say, I forgot to check this particular examination during your presentation. Make sure everything is done. Okay. So what are the domains tested and marked in the short case assessment? Okay, these are the domains tested. So physical examination is tested and given 20% out of 100. Eliciting physical science 40%. Interpretation of physical science 40%. Maintaining patient welfare, earlier it was given 10%, now it is taken out and it is given either yes or no. Remember, suppose this is marked as no, this is taken as a serious concern and this will be discussed by the chief examiner with the examiner panel. Okay? So, maintaining patient welfare is of a serious concern and it always needs to be done. Okay? So, the other important domains are the physical examination, eliciting physical science and interpretation of physical science. Those are the domains tested and given marks. Few words about other systems because it is different from the major 4 system. So, it includes areas which are not tested in the other 4 major systems. So, what are those systems? Musculoskeletal system, endocrine system, dermatology and ophthalmology. Okay. And candidate will examine 2 cases within that 10 minutes. Again, written instruction is given and most of the time you may get a clue with that written instruction. Read it very carefully. For example, inspect this patient's face and proceed to examine any other areas of interest. So, if you are asked to inspect the patient face, there should be something on that patient's face. It may be an acromegaly, it may be a thyroid eye disease. So, please examine. You need to develop your skill to identify a spot diagnosis. Okay? So, that may give you a clue and then to proceed. So, it depends on that spot diagnosis and your further examination depends on what you have found on that face examination. Or look at the hand and do the relevant examination. Okay. So, what happens on the exam day? Now, you have 2 examiners per station. Generally, one will be examiner in internal medicine, other one may be in an examiner from base specialty or maybe still in internal medicine. This may change time to time. They arrive early and see the patients independently and they calibrate. And then together they satisfy on the clinical science and interpretation. They need to come on agreement in the commands given to the candidates, the minimum signs to be elicited to pass the station, what are the false positives and negatives, what signs may carry extra marks, what are the differentials to be considered, etc. So, these things will be done before the exam starts. So, okay, so these are the general rules and regulations which are followed in each short case examination. Now, let me take you all through each system. As done in the long cases, I can't do the short cases here because you all know the short cases are very common. The common cases are always taken into short case. I can't do lively the short cases here. So, I will tell few tips for each systems here only. So, taking the general examination, as you all know, this is the most important part of the examination which needs to be done with very methodical. Now, at the PG level, you can't come there and think and proceed. It needs to be done very automatically. Okay? And always focus on the science relevant to the system. There is no time to do a head-to-toe examination. You focus on the science which is very relevant to the particular system and look for the heart signs and base your diagnosis with your heart signs. So, for example, cervical lymphadenopathy, clubbing or rashes or anything. So, look for heart signs. When we move on to the cardiovascular system, the major components are the general examination, pulse, blood pressure, jugular venous pressure and the precordium. Always remember to ask the examiner to give a blood pressure monitor. The examiner either will give a blood pressure monitor or will give a blood pressure value which may give you a clue for the diagnosis. So don't forget to ask for a blood pressure monitor. So what are the common cases you get in cardiovascular system? It's same as what you get in undergraduate cases. Okay. So mitral stenosis, mitral regurgitation or a mixed mitral valve disease, aortic stenosis, aortic regurgitation or mixed aortic valve disease, or any of the combination of all these 4 valvular diseases, ASD, VSD, Eisenmenger syndrome, prosthetic heart valves with or without complications, the same cases as you get in undergraduate examination, but the level expected from you all is higher than the undergraduate level. And then you all know what clues you may get to suspect whether it is mitral stenosis, whether it is aortic regurgitation, everything which I'm not going to discuss here. Once you identify or diagnose the case, always try to interpret in view of the pathology or the dominant pathology. Suppose you have got a mixed valvular heart disease, try to interpret the dominant pathology, the severity, etiology and complication for that particular patient. Now we see many of the candidates come and discuss the theoretical knowledge of whatever they know into that case. So always try to apply for that particular patient, what the patient has, what the science patient has, and discuss relevant to that particular patient, not the whole theory what you know. Respiratory system, the common cases are again the same: pleural effusion, apical fibrosis, interstitial lung disease, bronchiectasis, consolidation, lung masses, and so on. You know the system examination, the same: general examination, inspection, palpation, percussion, and auscultation. And abdomen, same cases: hepatomegaly, splenomegaly, hepatosplenomegaly with or without fluid, palatable kidneys, transplanted kidneys, same cases. Now, nervous system, let me go through bit in detail because frequently this system is not done well by the candidate. The sequence is often forgotten by the candidate. So please remember the sequence of examination of nervous system. Read the instructions carefully, whether lower limb, whether it's only the motor system or everything. And always do not forget the inspection. Remember the order. It is a problem. It is still a problem at the postgraduate level. Inspection, tone, muscle power, reflexes, coordination, sensory testing. It is very important that you do it in the order, so it is you can interpret it, your findings very easily. So what is expected once you have found your lesion, or once you have got your findings? What is expected in the nervous system is to identify where is the lesion and what is the lesion. Okay. Remember, a wrong interpretation at your level equally demonstrate the incompetency like missing sites. Okay. So always try to interpret it correctly. Try to identify where the lesion and what is the lesion. So all these things are expected from a postgraduate trainee. Okay. And modify the way you are testing continuously. Suppose now you have got a spastic weakness of the lower limb. When you are testing the sensory system, now don't waste your time to check your dermatomal pattern of sensory loss. You can easily go for a sensory level type of sensational examination. So always try to modify your examination according to the finding what you have already got. So what are the nervous system examination common cases? So cranial nerves often in combination, hemiplegia or paraplegia with or without sensory level, cerebellar signs, peripheral neuropathy, which is very common in short cases at the PG level. And the pattern could be upper motor neuron, lower motor neuron, or in combination extrapyramidal, cerebellar signs, or myopathy. Other system, as I mentioned, these are the common systems given dermatology, rheumatology, endocrine, and eye. What are the cases? As you all know, rheumatoid hand, psoriasis rash and the hand, ankylosing spondylitis, systemic sclerosis phases and relevant examination, Cushingoid phase and relevant examination, acromegaly phase and examination, thyroid eye and examination, and any ophthalmological examination can be given. So other than that, there could be some more cases. These are the common cases given. So those are spot diagnosis. These are not very difficult at all. Okay, so these are the short cases. If you go through, it appears easy, but when you do it, it may appear difficult. Okay, so in general, short cases check your clinical skills. That means examination technique, which needs to be very accurate, methodical, it should be very sequential. Okay, and also it check your reasoning ability, that ability to interpret your findings and form a differential diagnosis. It also checks the professionalism and communication, how you interact with the patients as well as the examiner, and indirectly the time management. Now, let me tell you what are the common mistakes done by the candidates during the short case assessments. Still missing the essential steps. This is the number one mistake. Okay, so essential steps means, say, missing to check the plantar response in the lower limb examination. Okay, missing to do a percussion in the respiratory examination. Always there is a tendency to take the stethoscope out to auscultate. Okay, so these are still the common mistakes. Wrong techniques or sequence of order. At PG level, these things cannot be accepted. Okay, so you will be definitely marked very low if you do a wrong technique or a sequence of order. Missing the general examination hard signs or obvious signs, ignoring the negative findings or failure to interpret the findings, those are the mistakes. Time management. Certain candidates spend too much of time on one aspect and fail to complete the most important examination. For example, try to find the apex for a long time and then spend minimum time on auscultation, and then they won't be able to come to a conclusion. Forgetting basic courtesies to the patient, unprepared presentation like poor examiner interaction, weak presentation skills, weak clinical reasonings, and so on. Okay. Overlooking common cases. Now, when you try to discuss the cases, some come out with the most rarest possibilities as the first differential diagnosis. Don't come up with that. We bring the common cases to the exam. We don't bring the rare cases to the exam. So please try to discuss with the common scenarios. Okay? So overlooking the common cases, this is also very common. So how you can prepare yourself avoiding all these mistakes and pitfalls the answer is to practice. So you strengthen your core clinical skills by practicing. Practice systematic examination routines until they become your second nature. Each examination should be focused, fluent, and logical. Avoid hesitation and repetition. So how you are going to prepare? Refresh the skills. That is your basics. Textbook on clinical skills and interpretation, clinical reasoning will help you. Examine as many patients as possible in wards and clinics. You will have enough patients in the wards and clinic, so please examine as you examine in the examinations. Practice. Now, whether the number or the quality of your examination matters, it is your quality of the examination that matters. Now, you see, just before the MD clinical examination, you go in groups and examine the patients. That may not help you a lot. Okay? You need to practice daily. Okay? Practice daily as you do for your exam. That is the answer. So, more than the number, quality of your examination matters. Be trained by your supervisor. They are often the examiners also. Okay, you can get your same supervisor as the examiner as well. Okay, so be trained by your supervisor. Attend the teaching sessions, trained by yourself. Get feedback from the consultants and colleagues after each case. Okay, attend the mock exams. There are enough mock exams, and attend them, and then you go and be the guinea pig and examine the cases, and you will get the feedback. Okay, so you will be very confident when you go to the clinical examination. Think clinically, not mechanically. Don't bring up all the theoretical knowledge and try to prove yourself, and present logically. Summarize the findings very clear and concisely. Say, for example, this patient has evidence of mitral stenosis with atrial fibrillation and features of right heart failure. This is very clear and a concise summary, which would follow with differentials and reasoning and a very good discussion. Okay? Be methodical, calm, and courteous. Practice mock exams with peers and supervisors under timed conditions. You may record yourself to check fluency and the posture. That is very important. Focus on the common exam cases, as I said. Rare ones are less likely in the exam. If you want, keep a small notebook of classic findings you have seen in wards and the revised spot diagnostic features when you do your short case appointment. You see enough spot diagnostic cases when you do the short cases, and those are the patients being brought to your other system examination. So keep a note on that. So on the exam day, when you go, how you can prepare yourself, don't be afraid of non-tough examiners. Now, among the trainees, I think there are rumors, there are set tough examiners. Don't get with that naming, okay? The non-tough examiners they are good examiners. People who laugh often may mark you very low than those tough examiners, okay? So don't be carried away with that naming. Don't be carried away with the previous day cases or leaked cases, okay? They are not going to help you. Of course, they will harm you, okay? Go with a fresh mind. Read the instructions carefully. Forget the previous station when you go to the next station. Start as a new case. You can very well compensate in the other station even if you fail in one station. It's a matter of the cumulative marks 50 at the end. Okay? So even if you fail in one station and if you do very well in the next station, that would really help you. Okay? So don't worry too much. If you have done very low in one particular station, you can still compensate on the next station. If you do all cases well, the chances of entering to your preferred specialty later definitely will increase. So that is what these sessions will help you to improve doing well in all the short cases and all the long cases and all the components of the examination, so you get high in the merit position. Do not create physical signs. Discuss as you discuss with your peers. Present logically. Answer what is asked. Maintain the patient welfare and professionalism, which is very important. Be mindful of how you treat the patients. They are human beings. Always remember that. Explain what you are doing and also explain what you expect them to do. That is very important in neurological examination. You have to give the commands very clearly, what you expect them to do. Greet them, introduce yourself, thank them at the end. All these things are important. Exposure. This is very important. Expose what is required only and cover them when it is not required. Now we do see, now when you start doing general examination, you expose the chest and do the general examination. It's not important, it's not essential, isn't it? You finish your general examination and then whatever is important you expose and do the examination and cover. It's very important, so please expose whatever is needed and then cover it once it is not needed. Consider the pain and other emotions, warn them before doing anything that may cause discomfort. Plantar response, trachea examination. So be careful and just warn them that this may cause some discomfort. Always try to put the patient in ease. At the end, the way you stand and present the case matters. Okay, be smart. Okay, so in summary, short cases test the art of clinical medicine. So to pass, you need to understand the basics. Cardiac physiology, neuroanatomy, differentiating liver, kidney and spleen, everything is important. See adequate number of patients systematically. Present what patient has, do not create the physical signs. You pass not by perfection but by clarity, confidence and clinical reasoning. Practice until every examination becomes natural and meaningful. A trainee who has safe technique, gets clear findings, put forward a logical reasoning with professional conduct will be the most successful candidate. Thank you.
Thank you, Madam, for that elaborative discussion on how to perform well in the MD Medicine short case examination. May I now kindly invite both resource persons onto the stage to present the certificates of appreciation.